May I have Dr. Akash slides? So before I start, one thing I would like to highlight here. One thing which I keep on telling that post-operatively the CRP ESR rises. It settles in about 4 months time, the ESR, and the CRP settles in about, actually ESR takes down later and CRP settles at around 4 months time. And we are doing a prospective randomized study of all our joint patients, pre-op, immediate post-op, and how the CRP settles down. Important aspect is that most of the time when the patient goes into the ICU and somehow we do a CBC, ASR, CRP or HB or even CBC and the WBC is high, the cardiologist or intensivist labels them as having infection. And they say that they diagnose the patient, that patient is having septicemia because of high WBC. So I want to highlight here in this slide that what is the optimal patient selection criteria for hemoglobin in total hip and knee arthroplasty, what is the CRP, how does CRP ESR comes down, and we should have an understanding of this because this has happened to me at least 3 times, and one of our eminent friend has also aspirated a knee after 3 weeks. So 3 weeks when you have a cold knee and knee which is looking normal, you aspirate, and that too aspirate in ICU, admitted for metabolic encephalopathy and making a diagnosis of septic knee. So we have to have the paper literature in hand, and we should read these papers to understand how much time does it take for the CRP, ESR and WBC to settle down. And to be very fair and frank, even in pregnancy the CRP rises. So the pregnancy is not a septicemic condition, but this happens very often in Patna, and therefore I have kept this session for understanding of our senior learned members and all the delegates as well. I would hand over the mic to Akash.
Thank you, sir. Basically, I am going to discuss few papers. In brief, I am going to talk about those papers, and at the end I am going to conclude based upon those. The first topic is hemoglobin in patient selection for total knee arthroplasty. So this is a paper on association between preoperative hemoglobin and postoperative moderate and severe anemia among patients undergoing primary total knee arthroplasty. It's a single center retrospective study. So basically coming to paper on the material methods, 474 patients undergoing primary TKR were identified. Patients were separated into those having postoperative moderate and severe anemia, which is basically hemoglobin less than 11 grams, and on postoperative day 1 and 3, and those without having any anemia. The aim of this study was to identify the risk factors associated for developing moderate to severe anemia postoperatively, and also to establish the cutoff values for preoperative hemoglobin associated with increased risk of postoperative anemia. Coming to the results of this paper, in primary knee replacement, postoperative anemia rate was prevalent around approximately 53%. So the significant risk factors for developing this were lower preoperative hemoglobin and more intraoperative blood loss. The ideal preoperative hemoglobin cutoff value according to this paper is 13.15 grams for males and 13.85 grams for females in primary knee replacement surgeries. So the patient with less preoperative hemoglobin should receive interventions early, such as erythropoietin, iron supplementation, and this is to avoid postoperative anemia and its associated complications. Coming to the paper 2, it says the association of preoperative anemia and postoperative hemoglobin and its association with hospital costs. The materials and methods. Since anemia is a risk factor for enhanced length of stay and its complications, this study analyzed if preoperative hemoglobin and postoperative hemoglobin were associated with total hospital costs and general ward costs. In this study, the anemia definition was taken as suggested by WHO, that is less than 13 grams for women, less than 13 for men and less than 12 for women. This study comprised of 367 patients from a single high volume hospital in Germany between 5th of August 2019 to 30th November 2020. Among them, 147 were men and 194 were women who received primary knee replacement surgeries. Among them, 21 had preoperative anemia among men and 21 had preoperative anemic women. So in this study, even confounding factors were taken into account, such as age, comorbidities, BMI, etc. So the results of this paper says, in patients with preoperative anemia, women had around 38,000 rupees extra higher general ward costs because of increased length of stay in hospital. And the total hospital costs were also higher by 23,000 for men and 17,000 for women. So the normal ward costs also increased by approximately 30,000 for men and 34,000 for women. The length of stay increases by a day for women, and it is not as much as men, it is only by around 1/3 of a day increase in men. So seeing these two papers, my conclusion on this topic is the ideal preoperative HB cutoff value to avoid post-operative anemia, which is both moderate and severe, since many patients won't be severe anemia because we will be screening out before the surgery. So they club together in post-operative moderate and severe anemia as a single group. Is for men it is 13.15 grams per deciliter, and for females it's 13.85 grams per deciliter. And patients with preoperative anemia should receive early intervention such as erythropoietin, iron supplementation, and blood transfusions. So the correction of anemia before surgery avoids complications that we frequently face, like post-operative anemia, delayed wound healing, delayed mobilization, post-operative infections, increased length of stay, which also causes higher financial burden on the patients. So seeing this, these are Western papers. So we have wide of Indian papers on this, since most of our Indian population won't match even these normal conditions. Since this is an elective surgery, Western papers suggest 13 for male and 13.85 for females, but we cannot achieve that in Indian population. So as a rule of thumb, we would like to go at more than 10 milligrams per deciliter as hemoglobin cutoff value for Indian populations.
Now I'll just wait, click on Dr. Sushil Singh. Dr. Sushil Singh, he has done a very wonderful study which is published in one of the international journals. And what is the ideal time when you should get the HB, and what is the most appropriate time? Day 1 we do it and then we forget it. Day 2 we do it and then they say it's significant or not. So what is the ideal time? Day 1, day 0, day 3, day 5, day 10 before they start? Yes, one more sir, please. Yeah, please.
And my understanding for a long time is the postoperative blood levels drop till day 5, no matter whether it's general surgery or orthopedic surgery. That's the third spacing in the leg is 5 days.
Yeah, I agree with you, sir. It's the day 5. Fifth post-op day is the actual day where we do the hemoglobin, and exact hemoglobin was there.
So I would just complete Dr. Sushil sir. Post-op day 5 is the most important day when you do a HB and then stratify what's the actual HB. Post-op day 0, I mean 1 is hemodilation. For hemodilation, you don't get the exact HB. Post-op day 2, we used to follow in England, but we have a paper by Dr. Sushil Singh, and it's an internationally published paper which shows that post-op day 5, and I am doing a prospective study in which we calculate the hemoglobin by Sally's method. Sally's method we do it, and we are also noting down the blood loss and everything. So post-op day 5, take-home message is post-op day 5 is the best day to exactly know when your patient's hemoglobin. It's not the post-op day 1 which is being done in all the centers, and we have infection in patients as they have wound infection, then we do the CVC and it is less. 5, 6 hota hai, and then we are lost actually. Now second CRP, sir. So now ESR, CRP, just give it a brief.
Thank you, sir. So C-reactive protein and erythrocyte sedimentation rate trends following total hip and knee arthroplasties in an Indian population. This is a prospective study. Coming to the paper on, it's a prospective study comprising 90 patients. Among them, 30 were unilateral hip replacement, 30 were unilateral knee replacement, and remaining 30 were simultaneous bilateral knee replacement patients. The serum CRP and ESR were measured on the day before surgery and on the post-operative days 1st, 2nd, 3rd, 7th, 12th, and at the end of 3rd week. So the results of this paper says that both CRP and ESR values were higher in THR patients. Then it is followed by bilateral knee replacement group and later in the unilateral knee replacement group. CRP rapidly reached its peak on post-operative day 2 and decreased in a biphasic pattern thereafter. And it normalized usually around end of the 3rd week. Whereas ESR levels peaked only on post-operative day 3 and gradually decreased, but yet it remained elevated even at the end of third week. So this paper says CRP is the best acute phase reactant in the early post-operative phase as compared to ESR. Coming to paper 2, it's a prognostic value of baseline high sensitivity C-reactive protein in patients undergoing joint replacement surgeries. The materials and methods of this paper, it's a prospective hospital-based blinded study conducted in Orthopedics Department of Calcutta National Medical College and Hospital, West Bengal. Totally 121 study subjects were selected from December 2007 till May of 2008. Blood was collected in pre-operative phase, perioperative phase and post-operative days 7th and 14th, and it was stored. Blood was finally analyzed on the day 14th post-operative. This was done to avoid any bias. Patients were divided into two groups, with the first group comprising CRP less than 3 mg per dl and the second group more than 3 mg per dl. The results were operative time was significantly higher in group with patients having higher CRPs, that is more than 3 milligrams per deciliter. Post-operatively, complications were also significantly higher in group with CRP more than 3 mg. So this paper concludes that higher CRP levels in patients with apparently no other risk factors are at higher risk of developing complications on second week after a joint replacement surgery. And also the operative time are also significantly higher in patients with a high baseline CRP level. So my conclusion based on these two papers are, CRP is the best acute phase reactant in early post-operative phase. CRP and ESR values will be higher, more in patients with hip replacement, then followed by patients having bilateral knee replacement, and in then patients having unilateral knee replacement. CRP peaks on post-operative day 2 and normalizes before the end of third week. ESR peaks only after day 3 but gradually reduces and still it remains higher even at the end of third week. So both ESR and CRP has more of a prognostic value than of a diagnostic value.
And all these clinical parameters has to be superseded or by reviewed again with the help of clinical examination. So we have to see the patient, see if the joint is warm, ROM is painful, whether the patient is on enoxaparin or something like that, and then take it from there. It's not the CRP, ASR which is high and then you keep on giving higher antibiotics. So my next, thank you Akash, well done. So now I have Dinkar Rana who will be discussing what antibiotics we give. So we'll have Dinkar Rana and ideal antibiotic which has to be given. So big question which